My name is Linus Fana. I'm originally from southeastern Nigeria, and I actually did my medical school in Nigeria before moving to the UK, initially for a postgraduate degree in public health. I've lived in different parts of the UK, in the course of which I met my wife, and about 5 or 6 years ago, we decided to settle and make our home in Bedford, where we had our two sons. And in terms of the work I do for the NHS, I am a GP in Central Bedfordshire, but I also work for the CCG as a strategic clinical lead for musculoskeletal health. And I sit on the BLMK CCG board, where, amongst other things, I have responsibility for care homes and frailty.
Why do you think it's so important to recognise the vaccine hesitancy that the local community is seeing? And how have you been working with residents to tackle this?
Yeah, I think it's really important to recognize the hesitancy in the community for a number of reasons. The first one is that people who are hesitant in the community, like everyone else, or even more so than everyone else, deserve to have good health and good health outcomes. And as the nation's healthcare service and as local healthcare leaders, I think it falls on us to do everything we can to give everyone the opportunity to achieve those equitable health outcomes. As you know, the purpose of the NHS is to provide care at the point of need, and therefore it was important that we provide care for these people and the opportunity where they needed it. I think it's also important to acknowledge that the nature of an infectious disease pandemic is such that individual choices can affect the community. And because of that, if we're able to respond to the needs that people have to have the opportunity to make better decisions, then we'll be more likely to help them to make better choices for themselves and their families. And therefore, we would also be helping to improve the health for the community. And if we were to fail to do this, then the problem then will affect everyone. So if I get vaccinated, but everyone else, or some people within my community doesn't get vaccinated, that means that I am still very much at risk. And the other reason is that we see how the pandemic has brought into sharp focus some of the disparities within our communities, and it was important to reflect and respond to that. And we see similar patterns in things like uptake of childhood immunization. We see similar patterns in uptake of national screening programs and in things like access to housing and education. So it was a really good target to provide intervention and to try and learn lessons which can then be potentially transferred to other areas of work within the health service and beyond. And so, for example, if we were able to, if we consider the burden of cardiovascular disease that we have, if we were able to make the blood pressure control of the people who have the least access to healthcare to be as good as the average individual, you will suddenly see a drastic reduction in the cost and the consequence and life outcome of cardiovascular disease. And it's the same thing for broader issues around life expectancy. If we can look after people who are left behind in society, then we will be more likely to begin to improve life expectancy again. And of course, we know that in recent times that's been stalling. We've been working very much as a team. I think that we've had the trust of community and religious leaders and also fellow healthcare professionals. And together, we've been able to organize engagement events in the community. What we've tried to do is to listen in these events to the concerns and anxiety that people express, and to respond to those concerns in a way that we try to respond to them in a compassionate, non-judgmental way. and hoping to give people the chance to get the information and empowerment they need to make better choices for themselves and their families. And we've done this in the form of online events. We've had also multimedia campaigns on social media, and we had radio talk shows. We focused on minority communities, on people that work in care and care homes, but also on religious groups within the area.
Has there been anything you've particularly learned from your experience working with those who are hesitant?
Yeah, I've learned a number of things. I think the most important perhaps is the realization, and it's not entirely new, but a better realization that people who are hesitant are not necessarily anti-vaxxers, and this is important because if we work on the assumption that there are anti-vaxxers, we may lose some people because many of the concerns and anxieties they have are actually very rational, and they are very relatable to all of us. And therefore, the way to go about it was to be able to understand that we needed to respond to these anxieties and to concerns to be able to address them in a way that enabled them to make their own decisions, and to and it's important to emphasize it's not just about providing correct scientific information, although that's important. It's important to know that it's about the difference in attitude to vaccines is how people use and relate to those scientific information, how people make meaning of it. And meaning making, of course, does not happen in a vacuum. People make meaning in the context of their pre-existing health beliefs, in the context of their previous life experience, particularly with the healthcare, but also with other areas of government and social services. And so by being very listening to them and encouraging them and trying to understand them, and enabling them to walk through some of these issues and anxieties, we are much more likely to have them make the right choice for their own health and for the health of their families and therefore of the community. And this, for me, was a really important realization.